Hi. So angina, more specifically known as angina pectoris, angina meaning the stroking and pectoris meaning of the chest, is, you could say, a cardiological disorder characterized by a lack of oxygen supply to the myocardium or the muscular system of the heart. It's a fairly common cardiovascular disorder. In fact, it's arguably the most lethal of them. We should also talk about some misconceptions of this disease, like how angina is just a symptom or presentation of coronary artery disease and not a disease of itself, and that there are other non-coronary artery causes of angina that we will discuss later on in this video. And yeah, hopefully this turns out well. Starting off with prevalence, the prevalence of coronary artery disease is actually quite significant. It is not a rare disorder, and prevalence shows a clear correlation with age progression, so it's unlikely for you to find this disease in younger patients. Unless there is an underlying health issue you should probably investigate. As you can see, almost 1 in every 3 men over the age of 80 can have an underlying coronary artery issue pertaining to how significant and prevalent the disease actually is. There's also the 20% and 6% that you can see in the ages of 60s and 40s, but let's be honest, not even the government could care less about those ages. Moving on to the etiology of coronary artery disease, or the causes of this disease, there are actually many, but a key point that you should probably keep in mind is that coronary artery disease is not exactly the same thing as angina. You see, angina is just a presenting symptom, and coronary artery disease is a mechanism of which that can actually cause this symptom to present, because there are other non-coronary artery causes of angina that we will discuss further on in this video. And to start off with non-coronary artery causes of angina, since it's easier to rule them out, they're actually more definite and a lot more rare. And it's important to distinguish these non-coronary artery causes of angina from the differential diagnosis or the other causes of chest pain that are not necessarily related to the heart, because angina in of itself is just a term used to describe chest pain that is cardiac in etiology or cause. So anything that causes chest pain that is not related to the heart is just a differential diagnosis of angina and not necessarily a cause of angina. Why, you might ask? Well, once again, it's because angina is purely cardiac chest pain. If it's not cardiac, then it's not angina. Now, out of the differential diagnosis of angina, esophageal pain is probably the most significant, not just because it literally mimics the burning pain of an angina, but because it also is relieved by the administration of nitroglycerin, which is kind of like the ideal drug for angina. That kind of tells you that before you could ever diagnose something like gastral reflux or heartburn as a result of esophageal dysfunction, for example, you should always rule out the more dangerous angina or heart attack. That's just common sense. So the graph here shows the difference between esophageal heartburn and the angina or the heart attack, and as you can see here, the terminology of heartburn is a little bit of a misleading title, as the result of heartburn is merely esophageal dysfunction, which is kind of ironic, but in medical terms it is what it is. Heartburn has nothing to do with the heart itself, but rather a heavy pressing, squeezing pain that is more characteristic of heart pain or angina. So I'll say it once again and I'll stress it. Heartburn, think of stinging, sharp pain, burning, characteristic of esophageal dysfunction. Angina, think of hard, pressing, pressure, squeezing pain of the chest, usually in the middle of the chest, by the way. Focus on the idea of being in the middle, because the pain of esophageal dysfunction or a reflux or anything in the upper gastrointestinal tract usually presents the left side of the chest more. So the pain in the center of the chest is more characteristic of heart. Also, keep that in mind, that's extremely high yield. Some other important characteristics of heart attack pain or angina pain is when the pain worsens with exercising and stress, or when the person exerts themselves, for example. And sometimes it extends towards the left shoulder, which is extremely specific to angina pain, by the way, or extends towards the jaw, and sometimes it can present as epigastric pain or pain of the upper part of the abdomen, especially in inferior wall myocardial infarction or inferior wall angina, between quotations, I guess. Talking about the heart walls, by the way, the clinical examination can reveal significant cardiac findings, ranging from palpitations, abnormal heartbeat, and shortness of breath, to even finding cardiac murmurs, especially in the case where myocardial infarction can include the heart valves. Pain that is not relieved by antacids can also direct us towards a cardiac cause of chest pain. Duration and accompanying or adjacent symptoms are a little less notable, but just keep in mind that heart attack symptoms are usually a lot more acute, but they rarely ever exceed the 1 hour mark. The other differential diagnosis is pneumothorax, where small pockets of air can develop between the lung tissue and the inner wall of the chest, which can also be identified or distinguished using percussions, where when you try to tap the wall of the chest, you might find an increased booming quality or resonance. This is called a positive percussion. There is also aortic dissection or rupture, characterized by a stabbing pain, skeletal-muscular pain, which differs based on the position or the movement, and a bunch of other diseases that it would take a little too long for me to cover in one video. Let's continue further with the etiology of angina, and like I mentioned before, there are coronary and non-coronary causes of angina as a symptom, and the non-coronary causes usually consist of anything that can force the heart to overexert itself. So we're talking hyperthyroidism, anemia, maybe something that can increase the muscular mass of the heart, such as aortic stenosis, which would cause the heart to have to build up more muscle in order to push the blood out of the valve. Aortic regurgitation as well can cause the heart to dilate, as more blood is going to flow into the heart with the initiation of systole. There's also hypertrophic cardiomyopathy, which is a genetic cardiological disorder, usually dominant in inheritance. There's also hypertension, which is relatively common. Phenochromoscytoma can be contributing, but it's a relatively rare disease. Finally, there's pulmonary embolism, which causes chest pain as a result of hemodynamic instability as well as coronary artery blockage. In rare cases, but the main mechanism of how pulmonary embolism causes chest pain is through hemodynamic instability rather than coronary blockage. Pulmonary embolism is actually a little complicated, and I will probably dedicate an entire video in the cardiology playlist for it later, but for now let's just stick to these basics. I guess we finally reached the conclusion of this video. We will continue hopefully in the next video the coronary causes of angina or the coronary artery disease, and I guess it's time for summary. So once again, if you couldn't take anything out of this video, just try to memorize these. So angina pectoris is one of the most common cardiovascular diseases out there. It has an increased incidence with age progression. The term angina pectoris refers to a form of chest pain, and it can be the result of coronary obstruction or non-coronary in etiology. The differential diagnosis of angina includes esophageal pain, aortic dissection or pain as a result of aortic rupture, skeletal muscular pain, and pneumothorax, and other different causes that should be taken into account when diagnosing angina pectoris. And remember that angina is more dangerous than those differential diagnoses, so it should be taken into account before those causes when they're being diagnosed. The term heartburn refers to esophageal pain. It does not refer to the pain of the heart. And the characteristics of cardiac chest pain is that it is squeezing, pressing, and twisting. It is not a burning pain. It is not a ripping pain. And in non-coronary angina, think of anything that causes the heart to overstress itself. So anything that can increase the heart load, like hyperthyroidism, anemia, in which blood does not have enough hemoglobin, so the heart would need to compensate for the blood's lack of its capability to carry oxygen, so it would undergo hypertrophy, which would eventually make it harder for the coronary artery to carry oxygen supply to the myocardium, or the muscle of the heart. And finally, I guess we've reached the conclusion. I hope that wasn't too much of a burden on anyone trying to watch. This will probably be the first part of the coronary artery disease lesson. And yeah, hopefully we can resume this lesson in the next video.